Second white coat. Subscribe and like. Let's learn medicine together.
All right, let's do a little medical detective work together. Today, we're going to solve a classic case, L5 radiculopathy. We'll follow the clues, piece by piece, from a patient's story all the way to the anatomical cause. And you'll see how one simple rule can make a really complex diagnosis feel, well, crystal clear. Let's jump in. Okay, so our story starts with a 63-year-old man. For months, he's been dealing with this frustrating pain that just keeps getting worse. Let's listen to exactly what he's been going through. You know, the patient's own words are always the first and maybe the most important clues we get. Sure, he's got back pain. But that phrase right there, sharp, shooting pain radiating down the right leg, that's our big neon sign. That tells us this isn't just a muscle pull. This is where our investigation really begins. And boom, the imaging tells the story. See that red area? That's our culprit. It's an osteophyte, basically a little bone spur, that's formed right between the L5 and S1 vertebrae. And look what it's doing. It's literally pressing on a nerve root. This right here is the physical reason for all his pain. So that shooting pain he described, it's not just a description. It's actually a diagnosis in disguise. Let's decode what that clue is really telling us. The medical term for this is radiculopathy. It sounds complicated, but the idea is actually super simple. When a nerve root gets pinched or irritated, it doesn't just hurt right there. It sends a pain signal screaming all the way down the path that nerve travels. So our patient's shooting pain is a textbook absolute classic sign of radiculopathy. Okay, so we know a nerve root is getting squeezed between the L5 and S1 vertebrae, but the big question is, which one is it? Well, luckily for us, there's a really simple anatomical rule that helps us pinpoint the exact nerve involved. Here it is. This is the golden rule for the lower back. A nerve root has to pass through a little bony tunnel called a foramen to get out of the spine. And the rule is, the nerve that exits that tunnel is named for the vertebra sitting directly above it. It's that straightforward. Now, let's apply it to our guy. Let's just walk through the logic here. Step 1. We know from the imaging the compression is happening in that tunnel between L5 and S1. Step 2. We apply our rule. The nerve is named for the bone on top, which is L5. So step 3 is the obvious conclusion. The nerve getting squeezed has to be the L5 nerve root. We found our nerve. This is where it gets cool. Now that we've identified the L5 nerve root as the problem, we can actually predict what we're going to find on his physical exam. See, each nerve root has specific jobs, certain muscles it controls, and specific patches of skin it gets feeling from. So, let's put on our clinician hats for a second. If the signal from the L5 nerve is being blocked by that bone spur, what specific movement is going to be a problem for our patient? What weakness should we be looking for? And the answer is, it's all about the foot and the big toe. The L5 nerve is the primary driver for dorsiflexion. That's the movement of lifting your foot up toward your shin. It also helps you extend your big toe. So a classic test is asking a patient to walk on their heels. If they can't do it, that is a huge red flag for an L5 problem. But it's not just about movements, right? It's also about sensation. The L5 nerve is responsible for the feeling in a very specific pattern of skin, what we call a dermatome. For L5, that patch covers the side of the lower leg and wraps around to the top of the foot. So we'd fully expect our patient to report some numbness or tingling right in that area. Now, you might be wondering, what about reflexes? This is a really important clinical pearl. You know, we tap the patellar tendon to test the L4 nerve, and we tap the Achilles tendon to test S1. But L5, it's kind of the odd one out. It doesn't have a single classic, easy-to-test deep tendon reflex. And that's critical because it means that having totally normal reflexes doesn't rule out an L5 issue at all. So we're feeling pretty confident about our L5 diagnosis. But a really strong diagnosis isn't just about finding the right answer. It's also about knowing why all the other answers are wrong. So let's just quickly confirm this by ruling out the other suspects. For example, if his knee reflex was weak or he had trouble flexing his hip, we'd be looking higher up in the spine, at the L2 to L4 nerve roots. If he had sensory loss up in his groin, that would point to L1, which is way too high. And a really serious red flag sign like decreased rectal tone would point way down to the S2 to S4 nerves, suggesting a different, more emergent condition. None of these fit our patient's picture. Okay, so after all of that diagnostic work, we can boil this entire case down to one simple, super powerful rule that's incredibly useful in practice. Here's the first part of the rule. If you see any kind of compression happening in that specific space, that foramen between the L5 and S1 vertebrae, your brain should immediately light up and think L5 radiculopathy. The anatomy is just that consistent.
And here's the second part, the punchline. When you suspect an L5 radiculopathy, the one key physical sign you have to look for is weakness when they try to lift their foot up. Weakness of foot dorsiflexion is the most reliable, most specific motor finding. So L5-S1 compression points to the L5 nerve, and the L5 nerve points to weak foot dorsiflexion. That's the whole game.
And there you have it. By connecting our patient's story directly to a clear anatomical rule, we solved the case. It just goes to show you the power of pattern recognition, of turning confusing symptoms into a clear diagnosis. Which, of course, leads to the next question, right? Now that you can spot this one, what other classic patterns might be out there, just hiding in plain sight?